Welcome back to SimWars, week 5, BLS and ACLS. I can see that our instruction that this is the most important lecture to attend in person really fucking stuck because there's like 25 people here and there's 150 people enrolled in SimWars. Which brings me to my first point. Well, not necessarily my first point, but a point nonetheless. SimWars signups are closed. We know this already. It's over. No more. Stay out. You can't come in. I'm sorry. It's just that way. We just have too many people, and it's not possible for you to catch up at this point. If you got an email saying that you're not allowed to come anymore and you think that was wrong, please let us know. I can promise you it probably isn't wrong. So if you let us know and the guys get back to you and say, no, this was right, don't come crying to me and send me an email being like, no, it's wrong. I support them 110%. This is like not elementary school where when your mom told you you can't have a friend over, you go and ask your dad. Doesn't fucking work like that. They speak for me. If they say that this is the way it is, this is the way it's going to be. All right? So I'm happy to answer any questions or anything you want to talk about. You all have my phone number. Just don't use me as a way to try to get around them because it ain't going to work. All right. So, moving right along. We have had a significant number of people show up to the practical sessions without reviewing the lecture and without having any knowledge of the lecture materials. Do you know how I know that? Is it because I'm like tracking who's watching the YouTube video? No. How do I know that? Because it's super fucking obvious. It's really, like an idiot could see if you haven't watched the lecture. We're not RCSI. You can't trick us. We've done this enough. We know if you haven't seen it. Stop doing that, all right? If you can't watch the lecture, especially this week, if you can't watch the lecture, don't show up to the practical sessions because this is a team sport. So if you show up to the practical sessions not having watched the lecture and don't know anything, you just drag your team down because all of a sudden I'm not giving your team feedback on how they're working together and how their communication is. I'm giving one person feedback in which I'm reteaching the fucking lecture. And that's not fair to the other people in the room. And I know I'm addressing the people in the room right now that are here and have been here pretty consistently. This is for the recording, and this is for everybody else. If you haven't seen this shit, don't show up. All right? In an effort to make this a little bit more fair, we're still not going to take attendance on this stuff. We're definitely reconsidering whether we're going to record these at all next year. But we're not going to take attendance, but we are going to start a little thing that's kind of like a secret password. All right? I see some lights going on in the room. So at some point tonight, I'm going to pick some shit from one of the slides. And I'm going to be like, that's the secret password. It's not a trick. It's going to be some obvious medical knowledge. I'm going to be like, that's the secret password. It's going to be easy to learn. You'll be able to learn it in like 5 seconds. But when you show up on Thursday or Saturday, the guys might ask you, hey, what was the secret password? And if you're like, what are you talking about? Guess what? You go home. You don't get to play the game with all the people that actually practice to play the game. You go home instead, okay? Real easy stuff. It's not going to be hard, I promise. I don't even know what I'm going to pick yet, but I'll pick it. Don't worry. All right, here's on a lighter, more fun note. If you have a friend or anybody that wanted to get involved in SimWars but wasn't able to meet the deadline for whatever reason, they've been on away placements, they're too busy, whatever, that's awesome. There's a way for them to get involved, and it's to get involved as a simulated patient, all right? This also goes for you guys. If you're like not sure about wanting to participate in phase 2, you don't necessarily want to go forward with doing the competition, but you still want to stay involved and like hang out with us, this is a great way to do that. So we put this up as well to everybody that either doesn't make it or doesn't elect to go on with the competition and move on to phase 2. If you're feeling unsure, you want a little bit more time, you just want to kind of hang out and learn more, this is a great way to do that. So take a picture of these QR codes, share it with your friends, share it with anybody you think could be useful. We give you some good training, we teach you how to be a simulated patient, and then you get a chance to kind of do some behind the scenes shit. that is really, really beneficial as far as going forward. And like Sean has not competed in SimWars. Sean is a SimWars coordinator by virtue of being like the #1 simulated patient and learning about all the behind the scenes stuff, right? So absolutely 100% a great way to be involved. There's some other fringe benefits that come with this. So if you join this group, it's not just for us, it's also for the Sauna Games guys. So we'll put out calls for like surface models, which, you know, take it or leave it, you have to kind of like be a little bit like naked in front of people, not like full naked, but like you have to let people touch your abdomen and stuff. So like you might not want to do that, and that's fine. But if you are interested in that, that's a great thing to do. And the third thing is we get a lot of requests from some of the hospitals in the area for simulated patients, and especially for ultrasound surface models for some of like the trainings they do with the doctors. Those are normally paid. They'll give you like 50 or $100 for the day to come out and just sit and let people scan you. If you're in this group chat, you'll be the first people to get notified if something like that is happening. So if you're like, oh man, I'm a little tight this month, need an extra $100 so I can go get some pints, boom, right there, it's the easiest $100 you ever make. You just sit there and let people run an ultrasound probe over you, and it gets you FaceTime with a lot of the emergency medicine doctors in the city, and you also tend to learn shit just by being around, right? So it's good. It's a really good thing to do. Adara's done it a bunch. Other folks in the society have done it. I don't know if you guys have done it, but it's super awesome. They bug us about it all the time, so we're trying to build like a roster of people that are interested in doing that, and it's a great way to get some extra cash. I know we're all med students, and like money can be pretty tight, so an extra $100 here or there, not necessarily a bad idea. And they normally give you food too. Cool? Yep, you're selling your body, but it's not like you're selling plasma or anything. It's just like pictures of your body. I guess that's not better. Look, dude, it's like ultra fans. Is that what you just said? That's good shit. Oh, that's funny. Okay, so that's it. We need volunteer patients. Get in this. It's just a quick Google form. We just ask for like your year in school, your email address, your phone number for a WhatsApp group. It's easy peasy. We'll also call in this group first for big stuff like trauma day. If you're interested in being a patient there, as opposed to like paying for tickets to go, stuff like that. So it's a really good way to just stay involved with the SOC and show up to things and hang out. So yeah, join it and share it around. There's no prerequisites. There's no actually, there's one prerequisite, which is to do surface modeling for ultrasounds. You have to be 18. I don't think that's going to be a problem for pretty much anybody at this point, but you know, that's it. But to be a mock patient, I don't give a shit how old you are. All right. Oh, this is, you all should know this because by virtue of being here. The lecture is on Tuesday. Today is Tuesday. Yesterday was Halloween. All right, so today is Tuesday. We have a Thursday practical this week and a Saturday practical this week. The Saturday practical is going to be longer to make up for the fact that we don't have a Tuesday practical. Makes sense. All right. We're going to do it. How many of you have gotten BLS certified by RCSI? How many of you have gotten BLS certified somewhere else? That's good. It's better to get it somewhere else. How many of you are ACLS certified? Cool. All right. Great. So some of this stuff is going to be a bit of a review. And if you know how this works, you know that the American Heart Association mandates that a BLS class is 4.5 hours long. And they mandate that an ACLS class is 16 hours long. You'll notice that the lecture tonight is not 20.5 hours long. It's an hour and a half. So we're certainly not going to cover everything that's covered in a certifying BLS class, nor are we going to cover everything that's covered in a certifying ACLS class. I'm going to give you the absolute bare bones necessary to be able to succeed in scenarios for the next few weeks, and then we'll talk more about it next semester, okay? This is not a certifying class. When you leave here tonight, you are not BLS certified, all right? If you leave here tonight and then come to a practical session and do real good and ask real nice, maybe I'll make you BLS certified, but not after tonight, okay? All right. And certainly no ACLS cards, because those cost me a bunch of money to print, and I'm not doing that for you guys. All right. This is the disclaimer. You should be intimately familiar with this at this point. Of all the people that stand in front of you and talk every week, I am the one that speaks for our CSI the least. All right, let's rock and roll. Okay, so it's week 5. We're going to talk about the basics as we always do. all right? We're going to talk about BLS, which stands for Basic Life Support, okay? BLS is Basic Life Support. It is a standard across the world. It is the American Heart Association's course for healthcare providers. So it used to be called like CPE for HCP, like whatever for healthcare providers. It's now called Basic Life Support. It is a classic. This gets conflated a lot, especially in the States, because there's also a level of care, like a level of ambulance called a Basic Life Support ambulance, which is a unit staffed only by people that are trained at the EMT level. It's fairly similar here, right? Some of those intra-facility ambulances that you see are BLS ambulances. These are two different things, right? BLS, getting BLS certified is not what you need to work on a BLS ambulance. You need an EMT certification to work on a BLS ambulance. That's confusing, right? But what we're talking about tonight is basic life support, which is basically just a CPR class. That's pretty much all it is. So that is at its core what it is. Anybody know what ACLS stands for? Advanced something life support, right? And again, advanced life support, also a thing, paramedic ambulances or advanced life support ambulances. And again, having an ACLS class, which is advanced cardiovascular life support, is not the same as having a certification that lets you work on an ALS ambulance. That is a paramedic certification. Super duper confusing. But at the end of the day, BLS is CPR, ACLS is CPR plus some extra shit, right? That's all it is. It's CPR plus drugs and a few other things. And a few algorithms that take us outside of the realm of CPR and into like other dysrhythmias and managing those. That's all these are, all right? There's a bunch of these multiple letter certifications that you will get at points if you're an emergency medicine doctor. You'll get things like ACLS, AMLS, ATLS, ITLS, whatever. At the end of the day, they're all just these different agencies' names for their classes that certify that you can do a set of things. So don't like get too confused by them because they don't actually matter. All right. Here's our learning outcomes. You'll notice it's pretty light because they're giant learning outcomes, right? Describe the AHA BLS resuscitation algorithm is a huge thing to know. It takes theoretically 4 hours to teach someone that. It doesn't in reality, but. And then describe the differences between stable and unstable patients. This is super important. This is a big takeaway for tonight, is to talk about stability versus instability, and we'll talk about that. We're going to talk about some common arrhythmias. This is not an ECG interpretation class. That will come later. So we're going to just talk about a few basic arrhythmias and what they mean and how to treat them. And then we're going to talk about some basic interpretation of 12-lead ECGs, and I don't think we really even get into that all that much tonight. There's a separate ECG series that we will put out in phase 2, okay? What are the basics? Airway. Come on. For those of you all online, they read out the slides really, really well. We've proved that everybody in the room can read. All right. This is what I was talking about before. So AHA, American Heart Association, BLS, Basic Life Support, Advanced Cardiovascular Life Support, ACLS. Lots of TLIs, which are three-letter initialisms, right? Lots of little fucking stupid acronyms that everybody's got to know, okay? All right, so BLS. One of the things that's super duper important when we start talking about these AHA courses is that these courses are designed to be universally applicable, right? So if you're getting a BLS certification, you could be a nurse, you could be a doctor, you could be a physiotherapist, you could be a paramedic, an EMT, a police officer, a firefighter, somebody that works in a daycare, right? So these are super broad certifications that are designed to be given to everybody, to give everybody a standard base. One of the things that we do with these is we do not ever assume that we're in a hospital. And in fact, even if we are in a hospital, this stuff still matters. But when we're talking about BLS, that basic stuff that we talk about, the ABCs, gets modified just a little bit, right? And you'll see some of the modifications here. The first modification is scene safety. If you leave here with nothing tonight, leave here with this. If you're walking down the street and you see somebody that you want to help, make sure that you're not going to die trying to do it. Okay? Because for me as a paramedic, I would much rather come to one person than two people. Because two people is twice as many patient charts, and it's twice as much bullshit to deal with, right? If someone's dead on the street, something probably killed them there. And I would like you to not get killed by the thing as well. All right? Now, maybe they had a heart attack, and that's not going to kill you. Maybe they got shot. Maybe they got hit by a bus. Maybe they're laying in the road, right? Scene safety is incredibly important. So when we start to talk about these basic life support scenarios, we're going to take you out of the hospital. We're going to say, oh, you're walking down the street in front of St. Stephen's Green, and you see a man down, right? This is real life. This happens all the time, and you have to be prepared to deal with it. Because as it turns out, being a doctor doesn't just mean being good at medicine in the hospital. It means being good at medicine anywhere. And there's a lot of doctors that fall short in that regard a lot, right? If you're on an airplane and the purser comes over the PA and says, is anybody on here a doctor? Who do they want? Do they want the interventional cardiologist that's only ever done heart caths for the last 20 years in the hospital? Or do they want the emergency doctor that knows how to deal with this shit in the field? Right? They don't want the podiatrist. They want us. And odds are, in a situation like that, a paramedic's going to be better than that interventional cardiologist because it's about being in the place that you know what you're doing. So, we need to teach you to be that no matter where you are. And that means scene safety, and that means calling for help, which is another really common one. And I bust your balls about it a lot in scenarios because you guys do the RCSI thing where you're like, we don't know what to do. Can we have senior help? And I always tell you no. That's different than this, which is I'm on the street, this person is dead, I would like to eventually get them to a hospital, which means I have to pick up my cell phone and call an ambulance to take this person to the hospital, right? And then the other big change is we've shifted a little bit when it comes to the actual core resuscitation guidelines to move compressions ahead of airway and breathing, right? There is some nebulousness to this. We've talked a lot about like unconscious, unresponsive person comes in, we start with airway, we go to breathing, we go to circulation, and that's all true. But we're adding one tiny little piece at the very beginning, which is make sure that they have a pulse first. Otherwise, start chest compressions, okay? I know that's a little confusing because we're taking a piece of circulation out of circulation and moving it up, but it's very, very important. We've learned a lot over the many, many years that we've been doing this, that the faster you get hands on the chest of someone that's in cardiac arrest, the more likely they are to survive to be discharged from the hospital, okay? So we need to get these compressions going first. So you're walking down the street, some guy's down. You check for scene safety, make sure something's not going to kill you. Whip out your cell phone, punch 999 and put it on speaker. Walk over to the person, try to wake them up. If they don't wake up, check a pulse, check if they're breathing. If neither, start chest compressions. All right? That's the story. And that works in SimWars scenarios too. And then if we don't start chest compressions, we roll back into our previous algorithm. If we do start chest compressions, we still roll back into our previous algorithm, right? We just have one person pumping on the chest. Cool? Great. Can everybody see that? I sure as fuck can't. It's really small back there. What is this? That's the BLS algorithm. That's it. Look at that. Isn't that cool? It's super easy, right? We check this out. Oh, this little fucker's in the way, isn't it? Oh, go away. Oh, well. All right. Okay. Nope. It's a lie. All right, whatever. It doesn't matter. So basically, what this is our BLS algorithm. I'm going to use the cursor here. All right, so you see up here, underneath this, it says went away. Unresponsive without normal respirations, okay? So we walk up to somebody, hey, are you okay? They don't respond. They're not breathing normally. And this doesn't mean they're not breathing. It means they're not breathing normally. Call 911, get an AED. And 911 is more of a guideline than a rule. There are places in the world where 911 isn't the thing. Other numbers work. So 999 or 112 here. 911 also works here, right? But call an emergency number, get an AED, assess the pulse. If we cannot feel a pulse within 5 to 10 seconds, We're on the chest, we're doing chest compressions. See that? No breathing or only gasping, no pulse. Start cycles of 30 compressions and 2 breaths. That's it. So you, as the first person on that scene safety, call for help. Try to rouse the person. Check if they're breathing. Oh no, they're not breathing. Check if they have a pulse. Oh no, they don't have a pulse. Your hands are on their chest, and you're pumping that chest. All right? 30 compressions to 2 breaths. What do we think about this? You're like, oh, that's fine. It can be absolutely tiring. So we run out of steam doing CPR in about 2 minutes, right? You become ineffective in about 2 minutes. So you want to try to get some friends together. The other thing I'll tell you is if you don't want to put your mouth on somebody out there in the street, I'm not going to blame you. You can just do hands-only CPR, right? That's what we teach people, bystanders now, is to just do hands-only CPR. It's much better than trying to dick around with getting a mask and do that if you don't have that. So 30 compressions to 2 ventilations if you have the equipment. Otherwise, hands-only CPR, right? Then we move on. The AED arrives. So here it says assess for shockable rhythm. You're a guy. You got a patient. You got an AED on him. How do you know if the rhythm's shockable or not? Yeah, I'll fucking tell you. This is what the A stands for. It's automated. Right? It takes the human out of the loop. You aren't the ones that decide whether or not the patient is shockable. The AED does in this situation, okay? So it'll say, shock advised, charging. At which point?
Step away.
Not quite. No? Keep going, right? So charging doesn't necessarily mean that it's about to go off. Every AED has a button that you have to press to deliver the shock. So while it's charging, we're back on the chest doing chest compressions. Once it's ready to fire, that's when we clear the patient and push the go button, okay? When do we start CPR after we push the shock button? Like immediately afterwards. Electricity travels very, very fast. So there's not like, patients aren't like weird little capacitors. They don't have like electricity left in their body that you have to let dissipate. I'm telling you this because people have asked me this shit before, okay? Like, it doesn't make sense, but it's, you know. So the electricity's gone as soon as you push the button. We're back in the chest. We're pumping the chest again. How often does an AED reassess that patient's rhythm? Anybody know? Every 2 minutes. What did I just say about how quickly you get tired when you're doing CPR? Every 2 minutes. Huh. If you had a friend, that'd be a really good time to switch out, right? There you go. So that's kind of how you plan your event. You start, get the AED on, then you're working around the AED because it's like clockwork. Every 2 minutes it's going to reassess. Perfect time to switch your compressors, get back in there, do it all over again. When do we stop CPR from a BLS perspective? Give me some reasons why we may stop CPR. How do you know if you get ROSC? Yeah, so if the patient's like, fuck, what happened? There you go. What else? Yeah, if you're just completely exhausted and you cannot continue. If you're like dead. 100%. What else? Hey, when the ambulance comes, probably not immediately when the ambulance comes, because I'll be like, oh, cool, people are doing CPR. That means I don't have to, so I'll just start doing advanced shit, as long as you're doing a good job. But the answer to that is if it's taken over by someone more important than you, right? So if someone is like, oh, I'll spell you, that's fine. What else? There you go. If it becomes unsafe for you to continue, if somebody walks up and puts a gun to your head and says, if you continue CPR, I'm going to blast you, then maybe stop. I don't know, man. Or keep going and see what happens. Most people are idle threats anyway. But give it a shot, you know? All right, so those are our kind of big reasons, right?
Give it a shot.
Don't do CPR if you're too gassed to do it. Don't do CPR if it's dangerous for you to do CPR. Don't do CPR if someone more important than you, and this is contextually more important than you, is like, hey, I got it from here, right? Because like, maybe you're a doctor and you're wandering the streets and a paramedic shows up and in that context they're more important than you, but then they go to the hospital and in that context you're more important than them. So, whatever. And don't do CPR if the patient doesn't need CPR, right? So we'll see signs of them getting better. They may start breathing again adequately. Their skin color may change. They may wake up. That's pretty rare, but it does happen. But some precipitous change in the patient's condition that lets you know, hey, maybe something's different here, okay? What about non-shockable? What if the AED says no shock advised? Then what do we do? Keep doing CPR. Fuck yeah, great stuff. All right. Then the other thing we got here is this little branch that sticks off the side. This is our rescue breathing branch. So this is a patient that does have a pulse but is not breathing. So we just breathe for them once every 6 seconds, right? We've talked about this already in our airway breathing stuff. So it starts to mesh together in a nice little way, right? All right. This up here is the real important stuff when it comes to CPR. So we talk about high quality chest compressions. When I say high quality chest compressions, what things am I looking for?
Depth.
So depth, great, define it. How much depth? What? Fuck, 2 inches? All right, you got a ruler? You gonna bust a ruler out and measure that? 5 inches, woo, baby, that's pretty deep. Anybody? Anybody? So I like, you're right, whoever said 2 inches, that's technically correct, but that's fucking useless in the real world, right? Because like, you're not measuring that patient's chest while you're doing it, right? Give me something easier. 1/3 the depth of the chest. A lot easier to see, right, than 2 inches or 5 inches or whatever. 5 inches is like fucking through the patient, so I mean, go for it if you want to. All right, so 1/3 the depth of the chest, that's a great depth. What else do I care about? So I care about, I'm hearing speed, I'm hearing rhythm. I'm going to say rate, right? What's our rate for good quality CPR? Staying alive. What else?
Baby shark.
Baby shark? Fucking garbage. Give me the number. 100 to 120. Any slower than that and it's not moving enough blood. Any faster than that and it's not moving enough blood, right? So 100 to 120. We heard some songs pop out already. I got Staying Alive, I got Baby Shark, All Star. What? Let the Bodies Hit the Floor. Another one, Bites the Dust. Pretty much every song is in there somewhere. There's playlists for this, all right? That's fine. Okay, what else do I care about? Quality CPR. What else do I care about? So chest rise, in what context? You're right, but you may be wrong. So releasing the chest, so allowing the chest to return to its full expansion. You're absolutely right. So we push deep, and then we let the patient's chest expand back to normal. When you watch CPR on medical shows, one of two things happens. Either they're not actually pushing the chest, they're just flexing their elbows, or they are pushing the chest, and they push all the way down and then never come all the way back up. The whole point of this is to circulate blood. So if we're pushing all the way in and then never letting it come back, we're circulating a tiny, tiny amount every time. Where if we let it come fully back to expansion, we're letting it fill up, refill those ventricles, and push again, right? So far we care about rate, we care about depth, we care about release, we care about the chest rising back up. What else do I care about? What's our good position? Nipple line. Very nice. If you see this on a test, the answer is the middle of the lower half of the sternum. Okay? Nipple line, or extrapolated nipple line, right? Theoretical nipple line, because sometimes the nipples leave, but think about where they would have been, and then do it there, right? What else? Don't bend your elbows. Now we're getting into how to not tire yourself out, right? If you're doing CPR, like you're working bis and tris, you're gonna gas pretty fucking fast, all right? So we lock our elbows, we position our shoulders directly above the patient, and we let our body weight do the work. This means that if the patient's in a hospital bed, we might want a stool for some of our shorter people. That's completely reasonable, and in fact, in most hospitals in resus bays, there's a fucking stool. What else?
Don't worry about broken ribs.
Yeah. Don't worry about broken ribs. In reality, what happens is the costochondral joints separate, and the sternum separates from the ribs. But like, yeah, don't worry about fucking stuff up. What else? What else is good quality CPR? It's the big one right there. Minimize interruptions, right? Absolutely minimize interruptions. To the point where we're starting to wonder if that time to do those 2 breaths is worth it. Because when we start doing CPR, we're starting from 0 pressure, right? In a perfect world, not a perfect world, the person's fucking dead. But in a world, we're starting with zero pressure. There's no circulating pressure. So the first few chest compressions, we're driving pressure up until we get to a steady state and we're holding that pressure circulating, right? It's like when you first start an aquarium pump. It's not like all of a sudden all the water's coming out. It starts to trickle, then it starts to flow. This was a wacky study done as part of the ROC, the Resuscitation Outcomes Consortium, where they like took pigs, killed them, put calves in them to see how much pressure there was and started squeezing them. It took a while for the pressure to build up. This is crazy medical shit. Like, you can do that, whatever. If that's what you're interested in, fine. As soon as we stop those chest compressions, that drops again. It drops back down to zero, and we're starting from square one. So this is why we want to minimize interruptions in chest compressions. So, as best we can, we minimize interruptions. When we talk about these patients, we start talking about advanced cardiovascular life support. Once we get a solid airway, we stop breaking for breaths at all. We just start doing breaths while we're doing chest compressions, all right? Because we want to minimize those interruptions. So we end up going to continuous chest compressions. And there's some data out there that says continuous chest compressions with an NRB dialed up to 1 million is better than chest compressions and ventilations anyway. So you may see that change coming down the pike eventually, who knows? All right, those are our quality of CPR things. So we care about rate, we care about depth, we care about chest wall return, we care about minimizing interruptions in chest compressions. Cool? This is the type of shit that we'll grade you on. This is the type of shit that in the competition, you'll be doing a resus, and one of the evaluators will have a stopwatch and time every interruption in chest compressions, right? That's how important this stuff is. Those are the things that are actually associated with increased survival to be discharged from the hospital. It's time to chest compressions and minimal interruption of chest compressions. Everything else doesn't fucking matter, right? It's all that. What's that? What is it? It's an AED. What is AED? I just told you. What's an AED? What does it stand for? Automated? External? Defibrillator. Okay. There are 1 million brands of AED. Everybody that makes medical devices makes like 3 or 4 AEDs. Because it's guaranteed cash money, because every fucking mall, airport, everywhere wants to have AEDs. And they charge 3 or 4 grand a pop for them, and they're super easy to build. It's cash money in the pocket, no effort, all right? So there's 1 million brands of these. You'll see a bunch of different stuff. The thing about an AED is that they are designed by medical device engineers to be as easy as possible to operate. People continue to get stupider, so they have to make the AEDs stupider. The original ones, when they first came out, had at least 2 buttons and often had other shit you had to do, right? Those are like Gen 1 AEDs where there was like a key and a switch and it looked like you were trying to launch a nuke, right? None of that shit anymore. You will see maybe 1 button, sometimes, but pretty rarely now 2 buttons. So if there's 2 buttons, one of them is the power on button. They've started to phase these out because people, when they get stressed out and go to push the shock button, they push the power button instead and it turns it off, right? So we stopped doing that because that's fucking dumb. So this is kind of the new, not new, these are pretty old, but this is the vibe that you'll see now, which is basically they automatically turn on when you open whatever case they're in, and they just stay on from that point. And the 1 button is the shock button. And that button flashes a bright light when it wants you to press it, okay? So if you see one with 2 buttons, make the determination that, oh, that 1 button is a go or a shock button and the other button's the on-off button. Don't fuck it up. But normally you'll see them with 1 button now. Some of the trainers have more buttons, and that's to like change the scenario that they're set on. Don't worry about that. I don't know if ours have those or not. Some of them do. But some of them will have like little toggle buttons for the instructor to use to switch the scenario. Yeah, most of those are remotes now. They have little RF remotes, but okay, there you go. So this is a classic one. This is the Power Heart. I think this is a Philips or Physio controller or somebody. But anyway, long story short, you open it up. Opening it up automatically turns it on, and it immediately starts talking to you. It'll say, tear open package and remove pads. At which point you tear open the package and remove the pads. Then it'll say, peel one pad from plastic liner, at which point then it'll say, place pad on patient's bare upper chest, at which point see, you can run ahead of them, right? You don't have to wait for them to prompt you to do everything if you know what you're doing. But if you forget, because these situations tend to be stressful, they will tell you. So they'll walk you through putting the pads on. Then it'll say, analyzing heart rhythm. Do not touch the patient. At which point don't touch the patient. Because it turns out CPR on an ECG looks a lot like VTAC. So you can really easily trick these things into thinking they need to shock a patient, right? After it does that, it'll say, shock advised, charging. At which point do chest compressions. Then it'll say, shock ready, push flashing button to deliver shock. At which point clear the patient, and then push the button to deliver shock. And then it'll say, shock delivered, continue CPR starting with chest compressions. And then most of them will start making a metronome noise, so you know exactly how fast to do chest compressions, right? That simple. We're going to practice these in the practical sessions. All right, that's BLS. There's some other random shit in BLS, like how to do the Heimlich maneuver. We'll talk about that later, all right? We already know how to do rescue breathing, right? 1 breath every 6 seconds. Good shit. This is ACLS now. This is running with the big dogs. This is the stuff that kids hate, because it's got all these drugs and shit in it. Look at that. What is that? It's the same fucking thing as before. Good job. It's the same thing as before. ACLS is just big BLS. So the whole point of this, and I said this once kind of in passing, there is very little evidence to support that any of the ACLS shit does fuck all for patients, right? Epinephrine kills patients. When we're giving epinephrine in cardiac arrest, yeah, it makes their heart start again, but it kills their fucking brain, right? It clamps down all the vessels. So the blood starts moving in the vessels that aren't clamped down, but your brain dies. Epinephrine is not associated with an increase in survival to discharge from the hospital, which is the outcome we actually care about. I don't give a shit if the patient survives and then is brain dead in the ICU for 2 weeks and their family finally decides to let him die. That's useless to me. I want people to walk out of the hospital back into the life they had before, which means that most of the ACLS drugs do nothing for you in cardiac arrest. All right? So, the moral of the story is, if you forget everything else, remember BLS. Chest compressions early, minimal interruptions in chest compressions. That shit saves people. The rest of it, we don't know. All right? Oh yeah, no, 100% you still get epi. That's the guideline, that's what we do, and that's what you're going to be judged against. But what I'm telling you is, in 5 years we might not be doing that anymore, right? And at the end of the day, if you forget everything else and you remember to minimize interruptions in chest compressions and get on that chest as fast as possible, you will save more lives than if you forget that shit to remember the drugs. Does that make sense to everyone? Great. That being said, you still got to know the drugs, because you're med students and it's really important, all right? So, ACLS gives us more than just cardiac arrest. So everything that we've talked to up to this point has been about cardiac arrest. The true meat of the ACLS and the drugs that we really actually do care about are the ones that help us with arrhythmias, like bradyarrhythmias and tachyarrhythmias. And that's where ACLS shines. That's what's different. So this is our algorithm of algorithms for ACLS. There's a bunch of these algorithms in ACLS, and there's even more than just these. There's some for like stroke and other stuff, and we'll talk about those. But when it comes to cardiac patients, this is how we pick our algorithm. So the first question we ask is the patient in cardiac arrest? How do we know if a patient's in cardiac arrest? They don't have a pulse, so you gotta check the pulse. And if they're in cardiac arrest, then we go to the cardiac arrest algorithm. So we go first to BLS, and then there's also an ACLS cardiac arrest algorithm. If they're not in cardiac arrest, then we care about their rate. If their rate is slower than 60, we go to the bradycardia algorithm. If it's faster than 100, we go to the tachycardia algorithm. Is everybody cool? Simple enough? If it's in there, if between 60 and 100, where do we go? Elsewhere. It's not ACLS anymore. Cool. That's Is that scary? Ah. Flow chart. Ah, scary. What is this flow chart? What is it? It's the ACLS cardiac arrest algorithm, right? That's what it is. Sometimes you'll see this represented as a circle. That's fine too. It's the ACLS cardiac arrest algorithm. So if we look at this, it's very, very similar. Activate emergency response. If you're in the hospital, are we calling 911? No, please. That's really dumb and embarrassing for you, and I'll show up with all my firefighter friends and we'll laugh at you. All right? So we're calling for help, unless we're in the emergency department and we are a resus team, at which point we're expected to handle it. But if maybe you're on the floor at a hospital and you walk in and somebody's in cardiac arrest, you're not just going to be like, ooh, boy, I want to do chest compressions. You're going to like push the go button on the wall and get some help, right? Cool. So we're getting help however we need to get help. We're starting CPR. See, give oxygen, attach monitor / defibrillator. Now we go to shockable rhythm. How do we know if it's a shockable rhythm if we're doing ACLS? No. AEDs are for basic life support. ECG. What are our shockable rhythms, people that are in senior years? VFib and VTAC, right? I'll show you what these look like. Don't worry, don't get scared. I know you don't know what they look like, and that's fine. VFib and VTAC. What are our non-shockable rhythms? It's a great rhythm. Somebody said asystole, that's a good one. What else? Everything else, right? Every rhythm that's not VFib or VTAC is a non-shockable rhythm. Cool. So I'm going to show you what VFib and VTAC look like. Then if you're looking at the cardiac monitor and you don't see what either of those, what is it? Non-shockable, that's right. Do I care if it's a complete heart block or a Mobitz type 2? I sure as fuck don't. It's non-shockable, right? So VFib and VTAC, shockable. Everything else, non-shockable. That is the extent of your ECG knowledge today. And that is all you need to run an ACLS scenario. You need pattern recognition to decide whether a rhythm is shockable or non-shockable. And I want to hear you say it, team leaders. When you're standing at the end of the bed looking at that cardiac monitor, you're not going to say, ooh, that looks like torsade de pointe. You're going to say, that's a shockable rhythm, right? And we're going to shock that fucking rhythm, okay? Simple as that. You're not going to be like, oh, that's a normal sinus rhythm at a rate of 78. You're going to be like, oh, that's not a shockable rhythm. Cool? I don't expect this crazy ECG interpretation stuff. Shockable v non-shockable. So, non-shockable. These are our asystoles, our pulseless electrical activities. We do what for non-shockable rhythms? CPR. Fuck yeah. Great. Any drugs we give for non-shockable rhythms? Anybody? I just told you one. Great. Epinephrine. That's it. Full stop. CPR, epinephrine. Epinephrine once every 3 to 5 minutes. 1 milligram. 1 to 1,000 or 10,000? 1,000. That's a lot of epinephrine, homie. All right. 1 milligram, 1 to 10,000. IV epinephrine. It is very hard to confuse the two because one of them comes in a cardiac arrest box. The other one is in a little ampule and given IM for allergic reactions. 1 milligram, 1 to 10,000 epinephrine every 3 to 5 minutes is your only drug for a patient in a non-shockable rhythm. That's pretty easy to remember, right? 1 milligram, 1 to 10,000 epinephrine is your only drug in a non-shockable rhythm. You give it once every 3 to 5 minutes. As it turns out, everything we do in CPR is done in cycles of 2 minutes. So give it once every 4 minutes, and then it happens at the same time every cycle, or every other cycle, really. Does that make sense? Cool. 1 milligram, 1 to 10,000 epinephrine, once every 4 minutes for your non-shockable rhythms. Great. What route do we give that epinephrine? Speak up now. IV? Good. All right. Or IO, if you're feeling frisky. All right. Now, let's go down our shockable rhythm algorithm. It's a little bit more complicated. So, what do we do for shockable rhythms? Well, now, hold on. What do we do for shockable rhythms? We do CPR first, right? We do CPR first. So we're going to do CPR. We're going to defibrillate that patient. So I know we talk about shockable versus non-shockable. One of the things that I want to start divorcing you guys from is the idea that we just refer to every sort of electrical intervention as a shock, right? Because there's 3 different kinds of electrical interventions that we're going to do. So when we start actually talking about this in scenarios, I want you to be specific about what we're going to do. So we're going to defibrillate these patients because they have fibrillations that need to be deified, right? We need to make those fibrillations go away. So we're going to defibrillate them. Cool? Cool. So we're going to do CPR. We're going to defibrillate them. What other drugs? What drugs can we give? Still epinephrine. Good stuff. Anything else? Little amiodarone. Yep. Little amiodarone. You see that guy on there? Nobody really uses lidocaine anymore. I don't know why. That's fine. Amiodarone is our other guy. So amiodarone is an antiarrhythmic. So if we think about this from a logical perspective, that VFib or VTAC is an arrhythmia, right? And we want to try to calm that down. So we're going to give an antiarrhythmic, which is our amiodarone. We only give amiodarone in cases that are refractory. What does refractory mean? Doesn't respond to the shocks, right? So if we're giving these defibrillations and we're still fibrillating, after 2 defibrillations, then we can start to consider giving our drugs. So we give 1 defibrillation, 2 defibrillations, epinephrine, defibrillation, amiodarone, and then we just go on down the line. What's our dose for amiodarone? Anybody? Come on. How many Spartans died at Thermopylae? 300 milligrams of amiodarone. Cool? Great. So 1 milligram of epinephrine, 300 milligrams of amiodarone. If we need to repeat epinephrine, how much epinephrine are we giving the next time? Still 1. It's 1 all the way down. That's why it kills your brain, because we just give it every 4 minutes until you have no brain left, right? What about if we need to repeat amiodarone? Anybody know? There's a real fun rule of ACLS for you guys to remember. If you're repeating drugs, one of 4 things can happen, okay? The first thing is you repeat the same dose. The next thing is you repeat with a half dose. The third thing is you repeat with a double dose. And the fourth thing is you're not allowed to fucking repeat, okay? So what do you think, amiodarone? Double or half? Half, good job, 150. So 300, if we do it again, it's 150, okay? Great. That's it. That's all we're gonna do. We're gonna do CPR, we're gonna do our drugs, and then we're gonna start into our ABCs assessment. So we may start thinking about things like advanced airway adjuncts, right? We may start thinking about things like getting the patient on a ventilator, stuff like that. But at the end of the day, the core of ACLS is chest compressions, good ventilation, and then we start thinking about our drugs, all right? Good stuff. What was that? Come on. Come on, what is that? Talk loud, I can't hear you. It's tachycardia. Good job. That's a tachycardia algorithm. I know it looks really small. Hopefully you guys can see it. All right, so there at the top, it says assess signs and symptoms, and then it says heart rate typically greater than 150 beats per minute. Why does it say that? Why do you think it says greater than 150? If greater than normal is 100. Because it's really fast, yeah. So what do we think about like a tachycardic patient with a rate of 120? Where do you think that problem is coming from? It could be stress. What else? Say again? Pain, great. So that's stress, pain, what else? We've taught you about a bunch of shit. Come on. Yeah, so we could be hypovolemic. We could be compensating for some type of shock, right? Yeah, so sepsis, another compensating for shock, is a great one. So the rule about ACLS is if you have a heart rate of 120 because you're septic or hypotensive or whatever, am I going to fuck with that trying to slow that down? No, because it's fast for a reason, right? It's fast because your body's trying to compensate for something. So when we look at this algorithm, we apply this algorithm in cases where it's fast and that's the problem and that's causing the issue, right? So normally the delineation there is if we get real fast, odds are that's not going to be a response to some sort of hypovolemia or to some stress or to some pain. That's going to be like the heart is running away and it's causing the trouble, right? Not always. Sometimes you can have patients that are clipping away at 170 and it's for some other reason. So you have to be cognizant of that and make that decision, right? We have had scenarios in the past that have not been ACLS scenarios with tachycardic patients that teams have been like, oh, we're going to cardiovert that shit. And that doesn't work if the reason the heart's going fast is because it needs to be going fast, right?
Is there any way to know when the tachycardia, if it's above 150, is due to something? Are there signs to look for in a scenario?
Yeah, what do you think? If you're hypovolemic, what signs are you going to look for? That tell you it's hypovolemia versus they're hypotensive because they have a tachycardia. No, low blood pressure is useless because you could be hypotensive because you have tachycardia. Nah, pale. They're gonna be pale. They'll be pale either way. Yeah, so if there's actual fucking blood in the room, that's a pretty good start. Which kind of knocks us onto the story, right? I was walking along, suddenly I felt my heart fluttering in my chest and I got really lightheaded and dizzy. That's probably a heart problem. I was walking along, suddenly someone hit me in the face with a baseball bat and then I passed out and now I'm tachycardic. Probably not a heart problem, right? So the story is very helpful in most situations, right? Our septic patients are going to maybe be febrile. They're maybe going to have a story that lines up with infection. So it's about being a competent doctor and actually trying to figure out what's wrong with the patient before you go zap them, right? All right, so let's say for the sake of argument that a patient comes in with a good story. They're 32 years old, otherwise healthy, walking along, and suddenly they started feeling their heart rate beat at a rate of 180 and they're super lightheaded and dizzy. What's the first thing that we care about? Airway, right? This patient is not in cardiac arrest. They are talking to you, which means we start with airway, baby, and we're back to the normal stuff, right? So we care about airway, breathing, and then we get to circulation, and then we say, now this is a problem that we need to deal with, right? So, see all this stuff right here? Good shit. Maintain patent airway. See that right there? Number one thing. Assist breathing if necessary. So ACLS does it for us. They say AB, right? Before C. If hypoxemic, administer oxygen. There's your B. Good B stuff there. Cardiac monitor to identify rhythm. So now we're in C, and now we're starting to ask questions like, why is this happening? Monitor blood pressure and pulse ox, IV access, and assess a 12-lead ECG. All great stuff. So we do our airway, breathing, circulation. At the beginning of this, I told you that there was one thing, one question you ask yourselves when it comes to ACLS patients. Do you remember what that was? Are they stable or unstable? Right? Are they stable or unstable? So this patient comes in, heart rate of 170, clipping along, looking like garbage. Are they stable or unstable?
Stable.
How do you know?
Well, they're staying at that condition.
Okay. Not necessarily. I didn't tell you that they had stayed at 170. But also, that's not necessarily what stable means in these moments, right? So we hear stable a lot in medicine. People will be like, vital signs are 120 over 80, blood pressure is 120 over 80 and stable, right? Stable versus unstable means a slightly different thing in ACLS. It is a rigorously defined set of criteria. So, what are some questions that we look for to see if a patient is stable or unstable? You don't even have to look, don't even fucking look at that. Just guess. No, don't look at that. Just guess. What are some stable or unstable criteria? Blood pressure, exactly. So what would make a patient unstable? Yeah, they're hypotensive. Great. What else? And when we say hypotensive, we don't mean like 110. There were a bunch of you in scenarios last week that went in there like, blood pressure's 102 over 70. That's really low. That's not fucking low. It's fine. I'm looking at like less than 100, and realistically in most emergency departments, you're looking at less than 90, right? All right, what else? Altered mental status. Good stuff. It's not up there. That's good. Is it up there? No. All right, great. Altered mental status. That's a great one. So acutely altered mental status. And I'm not talking about the dementia patient that's always like this. I'm talking about new shit. New person comes in. Whoa, this is different. That's altered mental status. What else? We got 2. There's 5. Give me a hint. There's 5. Hypotension, altered mental status. What else would make you think a patient's unstable?
Shortness of breath.
So shortness of breath, yes, affiliated with, you're right, it is kind of one of them, but let's keep going. What else? So heart rate is not, because you can have a tachycardia that is stable, right? We're looking at a tachycardic patient already and asking ourselves, are they stable or unstable? So hypotension, we've got altered mental status, what? Nope. Chest pain, and that's kind of associated with shortness of breath. Chest pain, shortness of breath, what else?
Hypoxemia.
Not technically, but you're kind of on the right track. So signs of shock is the thing that they say. So what are some signs of shock? Hypoxemia is one of them. Cool, pale, diaphoretic, right? Bad looking patient. One of the stable, unstable questions, the signs of shock one is literally interpreted by most people to be like, oh, do they look like garbage? Right? They look sick, they're probably unstable. I don't think I'm close enough to the mic, sorry. They look sick, they're probably unstable. What else? One more. And this is another kind of broad one. It's signs of acute heart failure, right? Which also kind of knocks on your shortness of breath thing. It fits in both. So shortness of breath, sign of acute heart failure, if it's new, right? It could be fluid filling up in the lungs, whatever. So chest pain, altered mental status, hypotension, signs of shock, signs of acute heart failure are 5 criteria to determine whether a patient is stable or unstable. You notice that heart rate is not in there. You can be clipping along at 210, and if you don't have any of those 5 signs, you are definitionally stable, right? So we make this decision, stable or unstable. Here is the true meat of ACLS. Yeah.
Would chest pain and signs of acute heart failure, sorry, I'm jumping.
No, go for it.
Going, but like, what would be the differences in what you're looking for there? Because to me, they feel.
So chest pain can be a sign of acute heart failure, but what are some, like, chest pain is a sign of some sort of heart problem, not necessarily heart failure, right? So our signs of acute heart failure, anybody want to help us out? What are we looking for heart failure? I know some of you are in senior years and you should know this. So that's kind of still fits in our chest pain stuff. So heart failure is different than heart attack, right? What? Yeah, that's a good one, edema. So where do we see edema? You see in the legs? Normally with acute heart failure, you don't get edema in the legs. Where do you get edema? In the lungs. Right? Because it takes a while to develop like pedal or sacral edema. So you see like fluid build up in the lungs, right? We see what else? So yeah, we can see that stuff that we already talked about, hypoxemia, right? We're not perfusing enough. So that's both hypotension, but it can also mean things like peripheral cyanosis, right? We're not perfusing enough. Cool? All right, so those are some things. So there's a lot of things. And there is some overlap here, like chest pain could be related to acute heart failure, or it could be an MI, whatever. But at the end of the day, stable v unstable, right? So here's the meat of ACLS. This is a common mnemonic. Unstable patients get the cable. Unstable patients have some sort of electrical intervention done to them, right? Stable patients get the drugs most of the time. Most of the time. So this is a tachycardic patient. They are unstable. What intervention do we do for them? We shock them. And here is the rub. What kind of shock? Ah, that might work actually. You never know. You can vagal people out of tachyarrhythmia sometimes. What kind of shock? We have defibrillation, and we have something called cardioversion. Has anybody ever heard the word cardioversion before? Okay, so let's talk about the difference between these two things. Real quick, What does defibrillation do? We just talked about it. It defibrillates. It stops fibrillation, right? So imagine, if you will, the heart is a lecture theater, and it's filled with people that continue to talk. And all of a sudden, I walk in and I go, shut up! That is defibrillation. All I'm doing is shutting everything off in the hopes that when it starts again, it starts normally, right? That's what that is. What about synchronized cardioversion? It's a little more special. So it's pretty much the same thing, except there's one key difference. And that difference is this. Imagine again, if you will, a big lecture theater. But there's one person in the audience that hates me. And if I yell really loud at the wrong time, they're just going to make everything worse, right? That's synchronized cardioversion, is timing that so that they're not there at the point that I yell. I wait for them to leave, and then I say, shut up. And then everybody calms down. In medical terms, has anybody ever heard of a phenomenon called R on T? This is like weird cardiology stuff. So basically, if you put an R wave on top of a T wave, if you try to depolarize the ventricles at the same time that you repolarize the ventricles, they go into ventricular fibrillation, right? Or they go into ventricular tachycardia. Synchronized cardioversion is timing our delivery of energy such that that doesn't happen, such that we wait just a little bit. And that's only ever important when we have good contracting heartbeats, right? So we do synchronized cardioversion to avoid that problem. So therefore, we only do it in patients that have a real rhythm, right? So synchronized cardioversion is our intervention, our electrical intervention for unstable tachycardia. Okay? We're going to talk more about that in a minute. What about if it's stable? Drugs. So look down here in our little guys right down here over here. Vagal maneuvers. What's that? No, don't fucking do that. Don't do that. No, don't do that. Don't do that. No carotid sinus massage. Carotid sinus massage is bad. Anybody tell you do carotid sinus massage, you say no. Don't do that. What do we do? What are some vagal maneuvers? Bear down like you're trying to poop, right? Blow into this syringe. Try to blow this syringe out. We're trying to give that vagus nerve stimulation. We're trying to increase thoracic pressure. Give that vagus nerve stimulation. The vagus nerve is functionally the brake of the heart. It innervates the AV node, and the AV node slows shit down, right? So vagus stimulation, we slow that shit down. What else we got? Adenosine, we'll talk about that. That's one of our doses. We got our little beta blocker, a little calcium channel blocker down there. Then bottom line, consider specialist consultation. Some of the times these people will stay in tachycardia until they see the cardiologist if they're stable, right? Doesn't fucking matter. They're stable. Great, move on. What's this bad boy? Bradycardia, good stuff. This is a little bit old. Don't pay no attention to the doses on here because they have changed a little bit. But bradycardia, what's the thought with this? Well, before that? Airway breathing circulation, right? And what about after that? Stable or unstable. Good stuff. Stable or unstable. What are our criteria to determine if this patient is stable or unstable? Same shit. Hypotension, altered mental status, chest pain, signs of shock, signs of acute heart failure. It's all the same. So stable or unstable. Unstable gets the cable. So what are we going to do for these people? Do we want to stop the heart? Fuck no. Because it's not going enough as it is, right? We don't want to be like, shut up! Because it's not really loud. So instead, we do something called transcutaneous pacing, right? This is when we put our pads on, and instead of giving big electricity that says stop, we give little electricity that says go, right? And we give that little electricity that says go once every, like 80 times a minute. And it tells their heart to go. And then it goes. It's not super comfortable, because you're getting shocked 80 times a minute. So you're going to be like, this really sucks a lot. So we're going to give them something to help with that, a little pain medicine, maybe some ketamine. Who knows? I'm not your dad. But at the end of the day, we try to get their heart rate up. So we give them pacing. So we call transcutaneous pacing. So we've got 3 electrical interventions. Defibrillation, defibrillates. Cardioversion, stops regular rhythms that are too fast. And pacing makes the heart go faster. Okay? Those are the 3. So if you're in a scenario and you say shock, that's not good enough. You got to pick out the right one, or else you're going to do something bad. All right? So, unstable gets the cable. What about a stable patient with bradycardia? What do they get? They could get drugs, but realistically they get nothing, right? A stable patient with bradycardia could be your like 80-year-old grandma that maybe needs to have a pacemaker implanted for like long-term care, or it could be your 25-year-old marathon runner that just has a heart rate of 40 all the time, right? So we make those calls based on the clinical picture. But at the end of the day, normally unstable bradycardia patients don't really get much from us. They get a cardiology consult if they need one, right? So you see right here, monitor and observe. And that's okay, right? So here's some pro tips. This is a little summary. So, we got our stable and unstable, and our bradycardia, tachycardia, and cardiac arrest. Stable bradycardia, what do? Monitor and observe. That's simple, right? Stable tachycardia. We can give drugs, or we consider maybe that there's some other cause to that tachycardia. Stable cardiac arrest is not a thing, so that's easy enough. Unstable bradycardia, transcutaneous pacing. Our other big drug that sometimes we give for unstable bradycardia is atropine. Everybody heard of atropine? No, that's okay. What does atropine do? I fucking don't care. What does atropine do?
Increased heart rate.
Okay, it doesn't really increase the heart rate. You know what it does?
It blocks the thingy.
It takes the foot off the brake, right? So atropine, the way atropine works, you're right, it's a muscarinic thingy, it's fucking whatever. Here's the deal with atropine, all right? Comes into the heart, there's a little cable in the heart that's down there, and it's this cable that comes from the brain that says slow down, right? That's what it's called the vagus nerve. It's hanging out in there, it's like, hey, slow down. Atropine goes in there and it just stands in front of that guy. So it doesn't speed up the heart, it just takes away the signal that says slow down, right? That's all it does. So it may or may not work for that reason. If the reason that the heart is slow is because of that guy, then it'll speed up. If the reason that the heart is slow is because of something else, it's not going to do anything, right? Because it's just standing in front of that guy saying, hey, don't do that. That's all, right? What's our dose for atropine? It's right there. 1 milligram, fantastic. I can't walk away from that. 1 milligram, awesome. You'll see in some places 0.5 milligrams. The reason you still see that is because that was the old guideline, it just changed. So if you see that, that person's not dumb or wrong, they just haven't updated their shit. There's one slide in here that does say 0.5, so don't look at that, because the algorithm is wrong. It's this, 1 milligram, up to a maximum of 3 total milligrams, okay? Atropine is one of these funny little goobish drugs that if you give a little bit of it, it can do the opposite thing. So that's why we give 1 instead of 0.5. Great? Okay. Then the other two, dopamine and epinephrine, those are both drip rates for pressing, like vasopressors that also have a chronotropic effect. We don't really care about those right now, but I want to put them in there because I want you guys to use this slide as a reference as we continue through the year, right? Tachycardia, we talk about cardioversion. So there are different energy doses for cardioversion. And this is an important thing to know. So we're doing synchronized cardioversion. 9 times out of 10, we're doing it on narrow complex regular tachycardia. This is your thing like your SVT, your supraventricular tachycardia. So you have a heart rate that's going real fast, but it's regular the whole time, right? So in that case, we're giving 50 to 100 joules. In reality, always give 100 joules. Because the rule is, if you give 50 and it doesn't work, give 100. And here's my thinking. If you ask a patient, hey, did that feel like 50 or 100? They're going to be like, I don't fucking know, it hurt. So just give them the big one first, and then we got to do it twice. You don't do it once. Cool? Great. So, 100 joules. We're talking about narrow complex irregular. Somebody give me an example of a narrow complex irregular heart rhythm. AFib, great. Talking about narrow complex irregular, talking about 120 to 200 joules. And there's a whole bunch of shit that goes on with AFib that we're not going to talk about tonight. Cool? And then if we have wide complex, which would be real bad, that would be if you had like VTAC with a pulse, which can happen, you can give 100. Great. And then our other little guy in here for narrow complex regular tachycardia is a little drug called adenosine. Okay? Adenozine's a little fun little drug. Anybody know how it works? Fine, I don't give a shit. Anybody know what it does? I want you to know what it does. What does it do? Oh, kinda. Oh, sure, kinda does. So adenosine is a fun little number that turns off your SA node for like 6 seconds. So it's a real good time. Gets up in there, shuts down the SA node for about 6 seconds. People, when they get it, they feel like they're gonna die. So you gotta tell them before you give it. You gotta be like, hey bud, for about 6 seconds, it's gonna feel like you're gonna die. Then you're gonna push that drug, you're gonna watch them be asystolic for 6 seconds, and then the heart will start back up again. So, what? No, it just makes you feel like you are gonna die. It doesn't hurt. You're just like, fuck, my heart stopped. That's bad, right? So, adenosine, that's a big dog. So that drug is a super interesting drug. It's only for narrow complex tachycardia, and it's only for regular narrow complex tachycardia. It doesn't work on AFib, it doesn't work on VFib, because if you think about it, if it's turning off your SA node, those of you that have taken cardiac anatomy, that's gonna do fuck all for AFib, because the stimulus is coming from outside the SA node, and it's gonna do fuck all for VTAC, because that's coming from outside the SA node as well. So it only works for our SA node-driven tachycardias. We don't want to give it to people that have not that, right? Adenosine, you know how I said there was going to be a little like bonus thing in here? A little secret password? Adenosine is the secret password for this week, right? So if I ask you, what are the doses of adenosine, you're going to say 6 milligrams, then you can repeat with 12 milligrams, and you can repeat with another 12, right? Twice. Yeah, 6, 12. There's some people that also repeat with 18 after 12. Yeah. So, but that's not what we're going to ask. We're going to just be like, what's the secret password? And you're going to be like, adenosine. Okay? Okay? That's the secret password. All right? That's it. It's adenosine. Good stuff. Don't tell people if they ask you. Keep it a secret because it's a secret password. All right? So that's that. So 6 milligrams, then 12 milligrams. All right? And if that doesn't work at that point, we're talking to cardiology anyway. And we're thinking about doing that synchronized cardio version. Then our cardiac arrest, we talked about this already. Chest compressions and epinephrine, plus or minus defibrillation and amiodarone, right? Everybody cool with that? There's a lot of drugs that start with A. What's that? What is that? That's a cardiac monitor. Great. So we have different skins for our cardiac monitors, right? You may see this, which is a LifePak 15. This is a really common pre-hospital one. You may see a Zoll Z1. You may see whatever fucking Medtronic is making now. You may see different skins of cardiac monitors on that little iPad. They can simulate all the major monitor manufacturers. Normally we use the one called generic, which is generic. But I'm putting this one up here tonight to demonstrate to you that at the end of the day, they're all the same, right? They all have the same set of things that they can do. And we're going to go over this real quick. So, this is a cardiac monitor. We turn it on with the on button. Cool. Normally they're already on when you walk into your scenarios. But if they're not, feel free to push the on button. Okay? So, if we're talking about doing a defibrillation, there's a few steps we need to take. And as it turns out, these guys are designed to help you most of all with defibrillation because that's the critical one. So it's over here where it says this 1, 2, 3, that's how you do a defibrillation. So you select your energy, charge, and then hit the shock button, right? Good? What energy do we pick? Ooh. What energy do we pick? Anybody know? Guess? 100? Okay, probably not, but close. What else? Anybody know what energy we pick? That's good, because it depends on the monitor. So each monitor has a guideline that says, this is my energy. And it depends on whether there's something called monophasic or biphasic. And I don't need you to know that. I don't need you to care. So at the end of the day, when you push that charge select button, normally it starts from the recommended energy. So you're either going up or down from the recommended energy. For this type of monitor, the recommended energy would be 360 joules because LifePaks are monophasic monitors. Doesn't matter. Bottom line is this. You select the energy that the monitor tells you to select. And if you don't know or you're still confused, turn it all the way up. Turn it up as high as it'll go. Normally they cap out at 200 or 360, crank them all the way up. If you see a Philips one, the Philips ones have a big dial that has all the different energy selections on it. There's one number that sticks out and it says adult dose right next to it. It's 150. You turn it to that, right? Easy peasy. So just pick the number that the monitor tells you to pick, press your charge button, hit that little red lightning bolt, and you're good to go, okay? What about if we wanted to do a synchronized cardio version? Oh, there's a button up there that says sync. Good man. See that? See that little guy right there, little sync guy right there? So same set of processes. The only thing different is before we hit that, actually really before we hit the charge button, but certainly before we hit the big red button, we're going to push that little syncy button right there. What you're going to see on the monitor is when you push the sync button, the monitor is going to start flagging each QRS. It's going to put a little notch above each big wave. That's how you know that it's synced, right? Because it's sensing those waves and it's going to deliver a well-timed shock around those waves. The one thing to remember is when it's in sync mode, sometimes it hangs a little bit before it delivers the shock. So when you push that shock button, it may not be instant. You may have to hold it down for half a second before it delivers it because it's waiting for the right time. Does that make sense to everybody? Great. If you want to pace, what are you going to do? There's a button that says pacer. You're going to push that, right? And then it's going to open this little menu where it shows you the number of beats per minute and the energy of each beat, right? What are we going to do? I'm going to tell you right now, because you don't know this. The pacer settings are 80 milliamps and 80 beats per minute. Cool? Just go with that. 80 and 80. It's easy to remember, all right? When we start pacing the patient, we care about making sure those pacing energy impulses are actually doing something in the heart. So we look for things called capture. So when we see our pacing, what it'll look like is a perfect vertical line on the cardiac monitor. That's because it's being delivered by a computer, so it's going to look absolutely perfect, and that's a pacer spike. Right after that, you should see a big QRS, like a big wave that is the heart responding to that impulse. If you don't see those, turn up that energy until you do, okay? Once you see those, we also care about what's called mechanical capture. So we want to take a pulse and make sure that it matches up with our paced rhythm, okay? So electrical capture, mechanical capture. Good stuff. Does anybody have any questions about this cardiac monitor? Now is the time to talk because we're going to get more interested in cardiac monitors over the next few weeks.
So when it says sync,
Yes.
is that doing all the work for you in terms of the wide complex versus the narrow?
No. So all sync is doing is flagging a QRS. So you still need to set the energy to the right energy based on what you see on the screen.
Okay. And then for the defibrillation, I just got a little bit confused because you said that the monitor will come with its kind of default almost, I guess, and then, but if you weren't sure to crank it all the way up, but then there was the 160 versus 360 or something. I'm just confused as to like what you would want to do.
Yeah. So when you're defibrillating a patient, the monitor has a guideline. You may not know that guideline because you haven't read the instruction manual, but it should show you that. So when I go in to deliver a defibrillation with this and I push that energy select button, the first number that pops up should be the normal dose that it wants, right? If you're not sure if that's the case, or if you push that button and it's something that's clearly wrong, like you push that button and it's like 2, you're like, that's not right, I'll just turn it all the way up, right?
Okay, thank you. Could you please re-explain what you meant by mechanical?
So mechanical and electrical capture. So when we're pacing the patient, what we're doing is giving the heart that impulse to constrict, right? So we are basically taking the function of the little node at the top of the heart that's the drummer for all the oarsmen. It's up there going beat, 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 and it's not going fast enough. So we step in and we use our machine, and it now is yelling really loud, beat, beat, beat. The little guys can ignore that and not listen to it, at which point we need to make him louder, so we turn up the energy, right? Until the little guys start to listen. When the little guys start to listen, you see the waveform on the monitor respond to that spike, and that's called mechanical capture. That's called electrical capture. We're seeing an electrical impulse that responds to our spike. that may or may not be mechanical capture. So they may or may not actually be moving blood. So we also need to get a quick pulse to make sure that we're also moving blood. Make sense? Yeah, good. We will show you what these look like at some point, I promise. But for now, know if you're pacing, we want electrical and mechanical capture, okay? There's actually slides for this.
This is no electrical capture. This is electrical capture. Every time there's a line, you're pacing.
I'll show you. I have slides for this. All right. So here is our easy peasy little chart for your reference for your ACLS drugs. This takes up one slide. I have removed everything that's like in ACLS but doesn't get used all that often. These are the basic drugs. This is for you to learn. What's the secret password? Adenosine. All right. So here's our uses. Here's our doses. You will see this get shifted around. So right now, the current ACLS guidelines is just 6 and 12. If you're practicing in a hospital in the States, you'll probably see 6, 12, and 12. There's some places that do 6, 12, and 18. So look, dude, I don't know. But 6 and 12 at the very least, okay? Amiodarone, easy peasy, 300 and 150. We can also give it as an infusion. We'll talk about that more later. Atropine, we talked about symptomatic bradycardia, 1 milligram 3 times up to 3 milligrams, right? Dopamine and epinephrine, dopamine is a drip drug. We're not going to talk about that super much today. We'll talk about that more later. Epinephrine, I want you to know the cardiac arrest dose of epinephrine, 1 milligram, 1 to 10,000 IV. We've also got the bradycardia dose, which is a drip, which I, again, don't care about drips for you right now. But we also have the anaphylaxis dose down here. That's actually 0.5. 0.3 is what's in an EpiPen. But it's 0.5 milligrams, 1 to 1,000 IM. And the only reason I want you to know that is so that you know that not to confuse the two. Cardiac arrest, 1 milligram, 1 to 10,000 IV. Anaphylaxis, 0.5 milligrams, 1 to 1,000 IM. I know that's crazy, but that's what it is. All right? And then magnesium, we're not going to talk about magnesium. This is in here as a reference for you for later. We'll talk about magnesium later. All right, it's time for cases. Yep. Case number 1, we got Jane Doe, 68-year-old female, presents to ED via paramedics complaining of lightheadedness and weakness for 4 hours. Airway, conscious and patent. Breathing, respiration rate 20 breaths per minute, non-labored. Sat 97%. Looking all right. Oh, shit. Boom. Circulation. What do we want to know? Okay. Pulse, 34 beats per minute, strong and regular.
Is she stable?
What do you want to know?
About heart, chest pain, all the rest of it.
What do you think about that? Stable or unstable? What if I told you that? Non-stable. Great, good. Good stuff. You can be a little unsure at 90 because maybe her blood pressure is always 90. But once I tell you she's cool, pale, and clammy, we're unstable, baby. ECG, sinus brady. You knew that before I even told you that because it's a regular rhythm. Sinus brady. Your little finger ECG right there. That's a sinus bradyarrhythmia. Do you see that? This is pattern recognition. I don't care if you know how to read ECGs, but that's a sinus bradyarrhythmia, right? That's what it looks like. Got a little bumpy, then a big bumpy, then another little bumpy, but they're spaced out really far away. I promise I'll teach you how to read ECGs, okay? Promise I'll teach you how to do that. All right, so where are we right now? And we are in the, which algorithm? Bradycardia algorithm, good stuff. So stable or unstable, we've got hypotension, yes. We've got altered mental status, we don't know, I didn't tell you. She told us the story, so I assume no. Signs of shock, yeah. Chest pain, we don't know, doesn't matter. All you need is one, right? Signs of acute heart failure, we don't know. Unstable bradycardia, what do? Yeah, we hit it with that pacemaker, right? We can also give atropine, and there you go, there's the 0.5 that I messed up. It's 1 milligram, and we can get that pacing going. 80 milliamps, 80 beats per minute. Good stuff. I'm going to change that real quick. Boom. Fixed it. That way no one's confused. All right, awesome. Case number 2, we got Gavin Richards, 35-year-old male, comes to the ED via paramedics, complaining of heart palpitations, dizziness, and pre-syncope. Somebody walks into your emergency department and says, I have pre-syncope. No, they don't. But they'll be like, I feel like I'm going to faint. That's pre-syncope. All right. Hey! Conscious. He told you, I'm feeling dizzy and lightheaded. He's pain airway. He's talking to you. Breathing. Respirate 24, non-labored. Oxygen saturation 95%. Not too shabby. We're doing okay. Circulation. What do we think is going to be wrong with this guy? Yeah, you're metagaming. It's going to be fast because the last one was slow, right? Hell yeah. Pulse 250. Happens. I have seen pulses that high. No cap. What do we care about? Unstable? Yeah, good stuff. Great. Skin, cool bale clammy, ECG, SVT. Supraventricular tachycardia. What does it look like? Well, it looks like that. It's got the same bumpies, but now they're way too close together. Crazy. That's SVT right there. That's actually like a little faster than 250. That's like bordering on 300. But there you go. That's a little SVT. That's what that looks like. Okay? Pattern recognition. Again, ECGs come later. All right. What are we going to do? Well, stable or unstable? He's unstable. We've decided already. So we're going to do narrow, regular tachycardia. Maybe think about adenosine. And we're thinking about synchronized cardioversion. 50 to 100 joules. What are we going to do? 100 joules. Absolutely. Good stuff. All right, case number 3. John Doe, approximately 60-year-old male, found unconscious by paramedics.
Compressions if he's raped.
A, unconscious. B, yeah, great. SpO2, see there's little dashes there. That's what it'll tell you if there's no pulse, right? So, C, pulse not present. Fuck off those compressions. Let's go. BP, obviously there's no BP. And obviously, like, his skin is cool and pale because he doesn't have any heart rate. Pretty great. What do we do? Yep, compressions, BVM ventilation. We do BLS. BLS before ALS, right? IV access. Maybe get our EKG, ECG going. Whatever we want to do. But we're doing those chest compressions. That's the key takeaway. All right. So, we start chest compressions. We're pumping away at the chest. Then we stop chest compressions, we look at the cardiac monitor, and we see that. What is that? Pattern recognition. What is that? VFib. VFib. All right. So VFib on the monitor looks like complete wacky craziness. All right. If you see complete wacky craziness on the monitor, that's VFib. Okay? It's that easy. All right. So that's ventricular fibrillation. What are we going to do? What? Continue CPR. What next? It's ventricular fibrillation, which means we want to defibrillate. Great. And then we can think about our epinephrine. And we think about, what about if it's recurrent? If we shock him twice and it doesn't go away? Amiodarone, 300 milligrams. Good stuff. EKG number 2. Let's take a look at another one. What's that? Pattern recognition, guys. What is that? VTAC. How do I know it's VTAC? Yep, they look like tombstones, a line of tombstones. They're all the same, right? It's not random garbage. It's a repeating pattern, but it's clearly not sinus because it doesn't have QRSs. It doesn't have those nice waves that we see. If you see something that looks like that, that's VTAC. Pattern recognition. All right, what do we do? Same shit that we would have done if it was VFib, right? Because it's just shockable rhythm. That, shockable rhythm. That, shockable rhythm. That's it. That's all I care about. That you recognize those as shockable rhythms. So it's the same shit that you would do for the other one. I don't care if it's VTAC versus VFib at this point. Great. Let me throw you another one. What's that? That's asystole, but I heard somebody say the actual thing that I care about, which is Non-shockable rhythm, right? There's nothing to defibrillate there. It's nothing. It's garbage. So what do we do? CPR. Give our epinephrine if we have it. That's it. So, we got some more stuff to go here. One of the things you'll hear people talk about a lot is the reversible causes of cardiac arrest, often referred to as the H's and T's. Has anyone ever heard this before? The H's and T's. I see some heads nodding. It's okay if you haven't. So when we start working a cardiac arrest, as we get further and further into our scenario, you know how I always tell you guys, if you run out of shit to do, go back to the top and start with airway? Right? I see some heads nodding. If we have a cardiac arrest that's kind of running itself and we're just in that rhythm where we're giving chest compressions, giving our drugs, giving our ventilations, and things are good, we can start to think about reversible causes, right? We start to think about H's and T's. So at some point during that arrest, the team leader is going to be like, okay, guys, we're in a pretty good spot now. We've done 3 cycles of CPR. Let's think about our reversible causes. Let's think about our H's and T's. These are our H's and T's. Do I want you to memorize this? Yes, I do. I do want you to memorize this. This is super duper important, right? H's and T's, very, very important. There's a few different ways people memorize this. You can just core memorize it. You can do what SJ does, which is kind of like a tour of the body. So she'll start at her finger and she'll say, okay, first thing, hypoxia, because that's where our pulse ox goes, so that's hypoxia. Thinking about that. Moving up to our arm where we get our bloods, so we're thinking about our hydrogen ion acidosis, hyper and hypokalemia, hypoglycemia, because that's all stuff that we get from blood samples. Moving up to the upper arm, we're thinking about hypovolemia, because that's where our blood pressure cuff goes. Coming to the core, where we're thinking about hypothermia, where our temperature is, right? That's a good way to do it. And then you get to the T's, and the T's are 2 tensions, 2 thrombosis, toxins, and trauma, right? So our 2 tensions are tamponade, where we have blood in the pericardial sac, the sac around the heart that's compressing that heart, or tension pneumothorax, same thing but with air in the chest wall compressing the heart. Our 2 thromboses, so coronary and pulmonary, either a myocardial infarction or a pulmonary embolism, right? That can cause our cardiac arrest, and then toxins and trauma, right? And realistically, tamponade and tension pneumothorax are almost always traumatic anyway, but toxins and trauma. Does that make sense to everybody? I do want you to memorize this. These are the things that we might actually be able to unfuck while the patient's in cardiac arrest and save their life, right? If they're in cardiac arrest because they don't have enough blood, we might be able to get them back by giving blood. If they're in cardiac arrest because they're too cold, we might be able to get them back by warming them up. If they're in cardiac arrest because they have cyanide poisoning, we might be able to get them back by giving them the antidote, right? These are the things that we do during the cardiac arrest that maybe will save the patient. Cool? Cool. Memorize H's and T's. All right. Somebody earlier said ROSC. Does everybody know what ROSC is? Good. That's good. We're going to learn something. ROSC is return of spontaneous circulation. So all ROSC is a fun, fancy way of saying we did it. We did the thing and we did good CPR and patient come back to life now, right? That's what ROSC is. So return of spontaneous circulation, the heart has started to work on its own again. How often does this happen? Not super often, right? This is not Grey's Anatomy, especially in the emergency department. Patients that are in cardiac arrest, more often than not, stay in cardiac arrest forever. However, sometimes we get them back, and it's good. So, if we get them back, what do? Start at the top with airway, my man. So, anytime we have a change in the patient's status, we go back to airway, right? So we have something called the ROSC checklist that you'll see printed out all over the place, ROSC checklist, but it turns out, starts with airway, then it's breathing, then it's circulation, disability, H's and T's, E, environment or exposure, where do we need to go with this patient? F, family and Foley catheter, classics. G, glucose and God. Why is that in there? Anybody know? Yep, exactly. Patients that were in cardiac arrest tend to end up back there again, so if you get a chance to get right with God before you go back down the hole, might be worth it. And then H is our kind of add-on here. Consider therapeutic hypothermia. And all I expect you guys to do is when you get to that point in the Ross checklist, be like, I'm considering therapeutic hypothermia. And we'll be like, good, cool. I'm not going to ask you to explain to me how it's done. We'll do that later, okay? So airway, breathing, circulation, disability, exposure, or environment. Start to think about the destination where we want the patient to go. This is all classic SimWars stuff, just distilled back down into another checklist, right? That's it. Ross checklist. Do I want you to memorize the Ross checklist? Yeah, I do, because it's the same shit that we do every single day, so you should know it already, right? All right. There's a couple other ACLS algorithms that I just want to hit real quick. So we have ACLS stroke and that's misspelled, ACLS ACS, which is acute coronary syndrome, right? So these are our ACLS stroke algorithms. This is for patients that are having cerebrovascular accidents, right? I'm not going to go through this in super detail because we're going to cover it more in phase 2, but I just want you to know that stroke is something that's covered by ACLS. There is an algorithm for it. It's a really nice algorithm. It kind of distills down our face, arm, speech time from symptom onset. Where are we going to go? Do we go to thrombolytics? Do we do CTs, et cetera, blah, 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 shit that we don't care about right now. But it is there. It does exist. So this is for reference for you. I don't expect you to know this right now. This is something that we're going to hit in detail come phase 2, okay? And then ACLS ACS is ACLS for acute coronary syndrome. So these are our patients that come in with the crushing chest pain radiating down the left arm. These are our heart attack patients. And again, we've already kind of taught you a little bit of how to deal with this, but this is it distilled down into a nice algorithm. We talk about trying to reperfuse the heart. We talk about going to PCI, stuff like that. So again, gonna focus on it more next semester, but I want you guys to know that this stuff is here and it is contained within the ACLS bubble, okay? That's it. Oh, Siri is listening to me. That's scary. Stop. All right, so the one other thing I want to do here is I had a bunch of people come up to me with questions about the hypothermia case from last week throughout the week. I think that was confusing to some people. Raise your hand if you were confused by the hypothermia case from last week. Please raise your hands, because I was a little confused by it. And I wrote the fucking thing. So, yeah, no, it's pretty confusing. So let's just talk about this real quick, just to get this out of the way, because I've gotten like 8 questions from people, and I know that I answered half of them incorrectly. So I want to just like set the record straight and make sure we get off on the right foot about the hypothermia patient. So we got Jane Doe. She was pulled from the water by the National Lifeboats, brought to the hospital. She was immersed for an unknown amount of time, right? She's very cold. We talked about this last week. She's unconscious. She's apneic. She's has a very slow pulse, 34 beats per minute, and thready. I want to correct something. Somebody asked me this week why we did CPR on her, and I said it was because she's in PEA. Clearly, she's not in fucking PEA if she has a pulse, so that's my bad, because that's incorrect. So skin, pale, cold, and dry, CPR in progress. So the question was, why is CPR in progress for this patient? Do we know why CPR is in progress for this patient? Not just because she's hypothermic. We want to get the blood going. And it turns out with hypothermic patients, we can't do that pacing thing. It doesn't really work all that well. So we're doing CPR instead, right? That's why we're doing CPR for this patient. She's got no blood moving around. She's got a really, really slow heart rate. And we can't pace her because it's not going to work. So we're doing CPR instead. Okay? She's not because she's in PEA. I made the mistake of answering somebody that offhand, and that was wrong. I don't think anybody that I told that is in the room, but if you see them and they're like, Blaze fucked up, I did fuck up, my bad. All right, so.
Just 1 second. She's also not breathing. Patients who are not breathing will eventually go into cardiac arrest.
That's also true. But we're giving her CPR in this case because her pulse is too slow. And the question that people came up to me with is, she has a pulse, why are we doing CPR? The answer is because it's too slow and we can't pace her, right? Okay. So vitals, 34 beats per minute irregular. Oh, it's going backwards. 34 beats per minute irregular. Respiration rate, 10 breaths per minute ventilated. So she's not breathing on her own, but we are ventilating for her so she doesn't die. Good stuff. Blood pressure, 60/30. That's bad. That's probably because we're pushing on our chest that it's even that high to begin with. SpO2 is 63%. Why is it 63%? It's because the blood is actually not getting there, right? The tissues are hypoperfused. So that 63% is because there's no blood in the periphery, right? And then temperature is really cold. All good. So this was the other confusion. Why don't we shock and why don't we do cardiac drugs? So why don't we defibrillate or pace or do anything to this patient? So not because she's wet. By the time she gets to us, she'll be dried off. So we talked about the drugs. The drugs don't work if it's too cold to work, so we're not going to give the drugs. The reason we're not shocking this patient is, one, there's nothing to defibrillate, right? She has a heart rate. It's 34. Defibrillating, that's not going to do anything. But the reason why we can't, when we look at a patient that's in hypothermia, even if she's in VTAC or VFib, we only ever hit that patient 3 times with electricity, right? If it doesn't work, then we stop, because all we're going to do is agitate the myocardium. So we can give it three shots, and then we stop. 99% of the time, by the time the patient gets to you, those 3 shots will have already been done by the medics, right? So if you get a patient delivered to you hypothermia in VTAC or VFib, odds are they've been defibrillated up to the 3 times that you can defibrillate them by that point. Because any competent paramedic is going to be like, oh, I'm going to do that, right? So that's why no shock, no cardiac drugs, right? Does that make sense to everybody? Great. Now, if you get the patient off the street, maybe you are going to defibrillate them once or twice, but this patient, not at all, because she has a perfusing heart rate. It's just too slow to actually perfuse, right? Great, don't care about that. Questions? Anybody in the chat with questions? Anybody in the room with questions?
Can a healthy person take adenosine?
You could.
You have some on you?
No. It'll be weird. It'll be real weird. But yeah, you can do it if you're healthy. It shouldn't slow your heart down any more than it already is.
If you want to like give ketamine or something prior to pacing or
Yep.
diversion, do you just do like before or during or?
So realistically, when you talk about unstable patients, we've binaried stable and unstable pretty heavily. In reality, there is kind of this gray area where patients are like unstable, but not so unstable that they can't wait 2 minutes to get the sedation. So like if a patient's actively crashing, you're just going to go straight for it, fuck it. But if they're like unstable, but not so unstable, you might give, a benzo or ketamine or something to kind of get them a little spacey before you do the thing, right?
Would they be expected to know those doses?
Not right now. All I want you to know is, hey, we're thinking about giving a synchronized cardioversion to a conscious patient. We should consider sedation. So we'll talk about the doses for that type of stuff when we get on to phase 2. That's a little bit beyond our pay grade right now. But in the competition, you actually absolutely would be expected to know that stuff. Other questions? What's the secret password? Great. Hand it over to Adara, and then we'll get you guys out of here.
Okay, so I just want to say, that was a lot of information. This is a really, really heavy week, and we go through a lot, and there's a lot of, really busy slides in this PowerPoint. Take a minute to go back over it on the website, because when you, if you take a second to just go through it in your own time, it will all make sense, and you'll realize it's not that hard. It's just a lot to pack into an hour and a half. But it is what it is, okay? But I recommend that you go through it. If there's a lecture that you're gonna go back through, this is the one. And that's why we also recommended that you guys come in person, because if you're just listening through this through a computer screen, it can just feel like too much, right? But go over it if you're not clear on this. I wanna talk about something very exciting and very important, which is the internal competition, okay? The internal competition is coming up in 2 weeks. Oh, it's not moving, oops.
You're running the wrong computer.
Oh, this keeps happening to me. Okay. That's what I was trying to do. Oh. Oh, it didn't update.
You have to refresh the page.
Okay, 1 second. Give me a second to figure out the tech, because we know how I am about tech. Okay, there we go.
Yeah, it's better.
There we go. What? Okay, sorry. So internal competition's coming up in 2 weeks. Originally I gave you the date of the 18th and the 19th. It has been brought to our attention that the 18th is the gem mixer, and it also worked out with our schedule, so we've moved it to the Thursday the 17th and Saturday the 19th. So if you're gym, either do it on the Thursday or do a hangover on the Saturday. That's up to you. So for the 17th, it's only going to be 2 hours from 6 to 8. You won't be there for the full time. You'll be there for like half. So you'll either do the early slot, which is like 6 to like 7, let's say, and then the latest slot is 7 to 8. So you'll be given one of them. On Saturday, we're running multiple slots because there's a lot of you. So we'll be there from 9 to half 2. You'll be there for an hour, okay? The same as we do with the practicals, we'll just send you a time. Okay, you're only eligible to participate in the internal competition if you've attended at least 4 practical sessions. That is the same that we always say that if you miss more than 3, you're out. There's 7 weeks, so it works out, do the math. And so you need to have attended 4 practical sessions. We've kept attendance, so if you sign up for the competition and in our records it says that you haven't attended enough, we'll tell you. If you think that's a mistake, again, please let us know. We have notes and things, but sometimes mistakes happen, so please let us know. The sign-up form will open now, and it will close in a week because there's a lot of scheduling that needs to happen, and we need time to do that because the scheduling behind the scenes is complicated. So it will open today, it will close next Tuesday, I guess, or next Monday, realistically, after the lecture. So if you want to sign up for the competition, make sure you do it, like you fill out the form during this week, because after that, we might not be able to accommodate you and probably won't be able to accommodate you, okay? Because there's a lot of you, so do it this week. And then we are still trying to figure out how much capacity we can have. If we have more demand than we have spots for, we're aiming for many spots, but there's also a lot of you. So if in the case that there's more demand, we will look at our records and we will allow people that have been there all the time before someone who has missed a couple sessions for no reason. If you were waitlisted or if you got sick, we have that in our notes as well, so that doesn't count. But if you just didn't decide not to show up one week and we don't know why, you will be I guess not prioritized above other people. But we're hoping that we can accommodate everyone. Okay, wrong laptop again. This is the QR code for the internal competition. If you want to be in the internal competition, fill out that form. If you don't want to be in the internal competition, also fill out that form and just say you don't want to be there, so we have an answer from you and we know what your position is. Before you sign up for the internal competition, I want you to consider a couple things. First thing, obviously, is that you'll be around the date of the internal competition. If you're not around that date, I'm sorry, I can't make another day for you. Another thing to consider is the internal competition is where we'll be choosing our phase 2 teams, okay? Phase 2 is quite intense. We have some lectures like this, which will be made available for everyone, so even if you're not in phase 2, you'll be able to see these lectures. But also there's a lot of practical involved. You're put in a team and you have a practical with your team and then a practical with all other teams every week. So in between the lecture and the practicals, and if you want to do your own study or any only team, no coordinators stuff, it's a lot of time. So we're looking at about 4 to 5 hours per week minimum, and that doesn't work with everyone's schedule. Okay, so before you tell us that you want to be in phase 2, really consider this and see if this is something that might work with your schedule. And finally, if you know that you're not going to be around on the 11th of March, don't apply for phase 2 because that's the day of the actual competition, and that's not going to change. And if you're not around, you can't compete, okay? So just really think about these things before you tell us that you want to be in phase 2. I'm pretty sure that's all I wanted to say about this. Is there any questions about the internal competition or signing up for it? Yes?
How are they going to be run? Is it the same kind of principle as the competition?
Right, good question. How is the internal competition going to be run? You're going to apply individually, right? So you fill out this form with your name and whatever else questions there are. You will be put in a team with other 4 people, the same way that you've been going to practicals. That team you will run through 3 different scenarios, okay? In every scenario, there will be a tutor and a coordinator that will mark your performance. We will share the marking sheets with you in advance so you know what we're looking at, but it's what we've been looking at the whole time and what we've been giving you feedback on the whole time, okay? So it's like the little bit of medical knowledge that is in the lectures and communication and team dynamics that we've kind of been working through in the practicals. So you'll go through three scenarios, 10 minutes each, and that will be it, okay? We're still deciding, just for time purposes, whether you're gonna get feedback on the day or not, but you will definitely get feedback after the competition, okay? Again, there's a lot of you, and we have to go through it one by one and write it up, so the feedback usually takes a couple weeks to come out because there's only so many of us, but you will get feedback, both general from like the whole group and specific to you, okay? So that's going to be kind of how the competition runs. You will be assigned your roles. So when you go into a room, we will tell you, okay, you're going to be the team leader, you're going to be airway, you're going to be circulation, and we've tried to schedule it so that those roles change in these scenarios so that everyone gets like a fair exposure. Because you're only doing 3 scenarios, not everyone in the team will get to be team leader. However, there are other roles that are very important in different scenarios. So we try to mix those around so everyone has like fair exposure, okay? And you're marked individually, but you're marked on how you work in a team. We saw a little bit of that last year where people would be like, were really good during the year, and then on the internal competition, like try to give all the answers to try to show that like you're great, but that actually hurts your team dynamics score, which is also very important. So just stick to what you've been doing for all of these weeks, okay? The prep for the internal competition is coming to the practicals, and everyone who's eligible has been doing that, so you should be fine there.
Just really quick, something I would have wanted to know in your shoes last year is that you also fill out what year you're in. So not that that's a total excuse to have lots of knowledge or no knowledge.
Oh,
but
yeah.
it's considered. Like, are you foundation year or are you an SC2 who's been on clinical placement?
Yeah, so for those online, Jen is just saying we will ask you what year you're in. This will not be used to say, okay, upper years will go into phase 2 and lower years will not. That's not why we want it. We want it so that the tutors know what level of clinical knowledge you have going in so they can mark accordingly. And we also will ask you in the form so that we can level out the teams, so that there's not like one team of all SC2s with a ton of medical knowledge followed by like a team of all of Ys, and then the comparison might affect the grades. So we ask so we can even out to make it as fair as possible, okay? The whole process, we're aiming for fairness in every way. And again, afterwards or before, if you have any feedback at all, and has everyone got a screenshot of this? Yes, okay, wrong laptop. We also have the feedback form. You can use this before the competition, after the competition, for anything at all, okay? And we really, really encourage feedback because we do look at it and we do use it for the following year, okay? And some of the feedback that we got last year, we've been trying to implement this year. Any other questions about internal competition? I know we've ran long because it's a very heavy lecture, so I'll let you go.
Until 9 in the SLHQ, so.
Okay. Everyone happy? Yes? Okay. Any other questions that pop up, text us, email us. Remember, if you email the emerge.doc email, I can't reply. If you email the SimWars email, I can reply, so just keep that in mind. But texts, emails, stopping us on the corridor to ask something. Just remember to fill this out within the week, because otherwise you might miss out, okay? Cool. Enjoy the rest of your evening. Thank you for coming.